Hi, attendees. Thank you so much for joining. We're going to get started at around 12 p.m. Eastern time. So we'll just chillax for a little bit here. Thank you all for coming, by the way. Hi, everyone. Thank you for coming in. We'll get started in about 5 minutes at 12 p.m. Eastern time, but thank you all for coming in early. Hopefully, for anybody who was in the last session, what did you guys think about it? Did you enjoy it? You can let us know in the chat. All righty. It is officially 12 p.m. Eastern time, so we can go ahead and get started. First of all, welcome to all our attendees. Thank you so much for joining this session. I'm just excited as you are to introduce the two wonderful speakers we have today. First, I'll introduce Dr. Sam Slade. Dr. Sam Slade is the current Emergency Department Medical Director at San Luis Valley Health in Alamoso, Colorado. Following his graduation from Toro University, Nevada in osteopathic medicine, he completed an emergency residency in Kingman, Arizona. Outside of medicine, Dr. Slade enjoys outdoor activities and traveling with his wife and 3 kids. Our second speaker for today is Dr. Samuel Jang. He's currently a PGY4 resident in the Combined Diagnostic Radiology and Nuclear Medicine program at Mayo Clinic, Rochester. He completed his undergrad at Northwestern University, his medical degree at the University of Wisconsin, an internship at Hennepin Health in Minneapolis. Outside of medicine, he enjoys playing tennis, making Korean barbecue, and spending time with his family. Dr. Slade will be giving a presentation on the DO perspective first, then followed by Dr. Zhang on the MD perspective. So without further ado, please welcome Dr. Slade.
Thank you so much. Can you hear me okay?
Yep.
All right. If I'm going to be using a pair deck, if you'd like to get involved in that, here's the number. It'll be up in the right-hand corner of the screen. I hope you didn't ask me to do this just because my name is Sam. I see Samuel's here with me, and I got a text from another doctor I know named Sam. And right after he said, "What's your email address?" Right after I sent him my email, I got invited to do this. I'm hoping that's not the only reason you had me do this, but thank you for having me. Such a great conference, looking at all the speakers and all the topics. This is going to be so helpful for somebody who's interested in going to the healthcare field. This is amazing. Thank you so much for doing this conference. Going to be speaking about the differences between MDs and DOs. So spoiler alert, once you get into your specialty, the differences is minimal. So you should consider going to DO school. During the biggest differences during DO school, we do additional training in OMT. It's easier to get into a DO school. They have average lower GPA and MCAT scores. On average, DO schools are more expensive. We'll talk about why. And if you go to a DO school, you have a much higher chance of matching to primary care in a rural residency. And the biggest hit is that if you go to a DO school, you're going to have a very steep uphill battle to match into a highly competitive specialty like derm or plastics. It's going to be extremely difficult, and we'll talk about why. All right, so this is kind of dating myself, but there's a movie that was called The Fugitive starring Harrison Ford and Tommy Lee Jones. It's got a famous quote like, "It wasn't me, it was the one-armed man." Maybe you've heard of it, but it was based on a true story of a doctor in the 60s named Sam Shepard. True or false on Peer Deck? Was he a DO? True or false? Oh, I can't see responses over here. Let's move this out of the way. Only 15 people are on here. I hope there's thousands is what I was expecting, thousands to be on here. But true, he was a DO. Not very many back in the 60s, much more now. So my story is that when I was going back to medical school, I was older. I didn't get into medical school until I was 32. It was my second career. You'll see that PE after my name. That stands for professional engineer. I'm a licensed engineer in Nevada. I had kids already before medical school. I had another one in medical school. Applying to my Nevada, where I lived at the time, Nevada, where I grew up. The first year, I got an interview. I didn't get into MD school. I retook the MCAT, got a much higher score, took some more classes. I had so many credits, it was hard to really affect my GPA, but it was good. I got another interview the second year, and I didn't get in again. And running out of time and resources as a father, and I just had to pull the trigger and go to DO school. And so I went to Toro, Nevada, which was actually worked out fantastic for me personally. I was able to stay in my hometown, live with family. It worked great for lots of reasons. I worked real hard in medical school, and then did everything I could to match into emergency medicine, which I really wanted to do. I did audition rotations, studied it. So that, and I ended up matching in emergency medicine, but rural, and that's going to be a DO thing is to match into rural residencies. What is a DO? It's a doctor of osteopathic medicine. It's medicine where they take all of modern medicine, everything that all of science can provide, as well as another aspect of treating the body and the muscles and the bones to make people feel better and to affect changes inside the body. More of a whole body approach to medicine. That's basically what it is. The differences in medical school. During medical school, as a DO student, you will learn and practice OMT, osteopathic manipulative treatment, where we manipulate the bones and muscles to improve pain, improve stiffness, and how that affects the inner body as well. How much of that is in medical school? In my estimate from classes and practicals, it was about 10%. And this is reflected in the board exams. It's about 10% of the COMLEX exams. Those are the tests you take as a DO. All right, another Peer Deck question. Are you guys interested in OMT? Anybody? Touching gross. I was trying to be funny, not interested, touching gross. Kind of, maybe. That's kind of where I was at. I'm expecting this one to be the highest. That's where I was at for sure. Like, I might be able to get into it. I'm kind of there too. Another difference in medical school is getting into medical school. When you're applying to medical schools, there's a MD system, and the DO system is this AACOMAS system. You put in your scores and your experiences and things like that, and you can apply to and your mission statements, and you can apply to multiple schools, much like the MD system, but it's a different system. And like I was saying, it's a little easier to get into DO school as far as MCAT scores and GPAs. They're on average have lower MCAT scores and GPA. Here's the numbers here for 2021. This doesn't mean that there aren't MD students who had lower scores than accepted DO students. And it doesn't mean that there's DO students that had higher scores than MD students, but there's so many factors that go into getting into medical school. This is just one of those, but it's a very important one. This, I think, is the beginning of where you get that stigma of the DOs being an off-brand doctor or a second-class doctor, is that they couldn't get into MD school. And that may be the case, but there's so many, like even if you had a 96 percentile on the MCAT score, it's not a guarantee that you'll get into an MD school. There's way more factors that go into this. And so it doesn't necessarily mean that they're second-class medical students. There's many reasons. But this is kind of where it starts. The cost of medical schools. Why is DO schools on average more expensive, like in the hundreds of thousands of dollars range? And it's because there's only one or very few DO schools that are state-sponsored, where the state pays for part of your medical education, whereas there's many more MD schools that offer in-state tuition, where the state pays for part of your tuition. And if you're going to out-of-state MD school, it's going to be much like what it costs to go to a DO school. So in my example, this year or recently, for Toro, Nevada, which is where I went to DO school, for all 4 years, it's about $260,000 versus if you got in-state tuition and University of Nevada, Reno, it'd only be $152,000. And that's based on in-state and out-of-state tuition. And there's many schools that offer free tuition if you get into that school, and that's factored in here as well. And more of those are MD schools. All right, another Peer Deck. What specialty are you interested in? I'm guessing you guys have been asked this a lot. Emergency medicine, there you go. We got some. Neurology is spiking up here. Surgery, yes. This is general surgery, I guess. Anesthesia's got a few. A lot of neurology. What's going on with you neurologists joining this conference? Zero urology. You guys are missing out. That's a great specialty if you can get into it. All right. Moving on. I wish I could hear some laughter out there and instead of talking into the void, but I'm Another difference in medical school, like I mentioned already. Oh, thank you for all the emojis. Thank you. Is that if you're a DO student, you take your board exams or the COMLEX exam versus the MD, which is USMLE. And this is another frustration for a DO in that these tests are different. And for I took both. I took USMLE and COMLEX, and my scores were very different, of COMLEX being higher. And it's very difficult for residency directors when they're trying to match medical students to compare those two tests. And if you can score better on the USMLE, that's better, because it's a harder test. They're different. What does that mean? Is that if you're going into a very competitive specialty, that you're going to have to take USMLE, which is another cost, which is more time, which is more study as a DO to match into a very competitive specialty like the ones we already talked about. So another frustrating thing for a DO who's trying to match into, if you're trying to match into rural medicine, family medicine, just take the COMLEX. You're going to be totally fine. Differences in residency. There is endorsement for OMT in some residencies. You're going to know about this before you apply to those residencies where they may require you to continue doing OMT during residency, but you'll know about that. And if you're interested in it, you'll look for these, of course. And then, like I already mentioned, once you're a practicing physician, you get paid the same, you're treated the same. If you can get into the specialty, it's the same. But much more match into rural primary care as a DO, and not nearly as many for highly competitive specialties. Those are much more for MDs. Peer Deck, can you bill Medicare for OMT? This is the osteopathic manipulative treatment. Can you bill Medicare for that, and insurances? I don't know. Yes, no. There's mixed, right? It's a question you don't know, right? And you can, and it actually bills very well. It bills like a procedure on top of your office visit. So it can be something to help your income if you go to DO. Patients like manipulative treatment. They like being touched. They like not using, being reliant on pharmaceuticals if they don't have to. It helps a lot of people. They like it. It works for them. So it is a worthwhile practice. Some similarities. It's the same prereqs to get to MD and DO school. Once you're in DO school, it's extremely rigorous, very competitive for those top spots. It's not an easier medical school for sure. I had cadaver labs. It's going to be very similar education besides the OMT, which we already talked about. This similarities in residency training, it's the same. They're all accredited by the same body. All the residencies are open to MDs and DOs. So very similar once you get into that specialty, which we already mentioned. All right, last Peer Deck question. I'm finishing up here. Thor, Love and Thunder came out. Mixed reviews by the critics, but I enjoyed it quite a bit. This is more of a question based on the comics. In the comic book store's alter ego was Donald Blake. What was his profession? You're going to have to assume it's medical related. Oh, some of you, I tricked some of you. This is, he was just a doctor to the superheroes. So I appreciate you guys thinking he was a DO, but there you go. No, I already told you the answer. Now the more people are guessing the superhero one, but this is just the review slide. The biggest differences is it's the MCAT scores are less to go to a DO school, so it's easier. You're going to match if you go to DO school. You're going to match much more likely in primary care in rural areas, and it's going to be very, very difficult to match into the most competitive specialties as a DO, MD. And talking with Dr. Jang before this presentation, he said, "What are you going to say that isn't already said on YouTube?" And I was like, "Oh, there's stuff on this on YouTube." So I went and watched a bunch of YouTube, and the difference between me saying this, it's very, I agree 100% with what they say. You're going to go to watch those videos and you're going to see the exact same thing I already said. The difference is those guys are the top 1% of the top 1%. Plastic surgery matching MDs are saying this, and you're going to say like, "Oh, this is biased against DOs." And now you're hearing it from a DO saying it, and you're going to know that what they say is, and I agree with what they said. So that's it for me, and I'll be here for the questions.
Thank you so much, Dr. Slade, for the DO perspective, and now we'll move on to Dr. Jang for the MD perspective.
All right, thank you, Dr. Slade. Please rejoin. So you might have to, I guess, close your browser and then open up joinpd.com again and put these letters. There's no space in the middle. It really annoys me that it looks like there's a space in the middle. Do we start? All right, and give me a thumbs up if you can hear me. Thank you, Dr. Slade. All right. Not sure if I started this correctly. Well, let me do some. I think it worked. Okay, moving on. All right, part 2. So something just fun. Show me where you're at. You can click on the state and tell me where you're at right now. Some people overseas, not in the US. Awesome. Lots of coast distribution, no love for Texas or Minnesota where I am right now. Awesome. All right, just wanted to try this. All right, moving on. So Dr. Slade shared his presentation with me prior. So I copied his format just to be consistent, including the template. So as he said, once you become a doctor in your preferred specialty, your degree really does not matter. And I completely agree from my own experience. I will make arguments that being an MD program does provide some opportunities on average than DO programs, and I'll be touching on the listed topics. But most importantly, regardless of what you do, you will not, or please do not, regret your decision. I had a friend who's an international medical grad who tried 3 times to match into general surgery, could not, and he matched into psychiatry, on his 4th try. I asked him recently, do you regret not going to surgery? And his answer was, heck no. Like, he's very glad he's into psychiatry. We generally are happy or where we at if you're a, healthy, thinking person. A lot of my background was covered in the introduction, but I only applied to MD programs. I was only introduced to DOs when I was shadowing, and then in my school there was DO professors, and I freaking love them. And I worked with DO colleagues during my internship in Minneapolis, and they were all excellent doctors. I did work for a year with BMO Academic Consulting, helping pre-meds like you get into med school. So I got to help a lot more pre-meds, navigate their application process in both MD and DO programs. I'm married to an ophthalmologist. I have a 3-year-old boy and another on the way. I'm currently in Mayo Clinic and right now applying to fellowships. I did summarize my journey in a video in my YouTube channel listed here. It goes through all my stats and my activities if you're interested, and the results that I got. All right, what do I do for fun? I travel a lot. It snows in the winter, so I like snowboarding. Just 2 weeks ago, I was in Vienna. I'm a part-owned shareholder of the Green Bay Packers. So I grew up in Wisconsin. I like playing tennis and spending time with my church people. All right, now let's get to the differences. The first thing I'll cover is the philosophy. A lot of these, videos that Dr. Slade mentioned, or these articles comparing the two, starts with like historical perspectives on where MDs and DO come from. If you're a good doctor, you're a good doctor. You have medical knowledge, you're empathetic to your patients, your decisions are based on medicine and evidence if they can, and you think of the patient as the whole, not a disease. So this cartoon is kind of getting at that. This patient wants a doctor who's available to answer his questions or help him, is what this cartoon is getting at. So there's really no difference in what's being taught in the schools except for OMT, as Dr. Slade mentioned. In MD school that I went to, I did not learn any manipulative techniques. A issue that I was recently introduced to was, I thought, all medical schools had affiliated hospitals, and the school that I went to, University of Wisconsin, has a teaching hospital associated with it, and that's where I do most of my rotations. So, when you're looking into programs, you should ask, does the medical school have affiliated hospitals and how the rotations work? Not that not having an affiliated hospital is bad, but you want to know, be able to plan your future. For example, a lot of the DO schools are newer because it's a newer degree, and there are also newer MD schools where they're affiliated with nearby local hospitals. But sometimes you'll have to travel for clinical rotations, which comes with good and bad. If you have commitments outside of medical school, like you're part of like a, I don't know, a tennis team, soccer team, part of a church, or you have family, then traveling might be inconvenient. But some people might like the ability to go to other hospital systems and check them out and rotate in those places under very different attending doctors. As I said, vast majority of MD schools have affiliated teaching hospitals. At Wisconsin, I did it at the main campus, but we did have the option of rotating at other rural hospitals and clinics in partnership with Wisconsin or their rural clinics. But regardless of either programs, you will be able to apply and rotate at possible desired programs right before the application season. And I think Dr. Slade did that too for ED rotations. And for emergency medicine, they kind of require that. So it's good to show and demonstrate your enthusiasm and your, what you got to them so that they will like you. All right, I'm gonna go a little deeper into the residency opportunity. So, it is pretty much accepted that going into MD school will help you match into more competitive specialties than DO. But this analysis does the best job at looking at comparing MDs and DOs. And it might be a little dry, but I just wanted to give you the best evidence for what this looks like. So, matching is the process where medical students get into a desired subspecialty. You rank all the programs that you interviewed at, and all the programs rank the applicants. And you get into one place, and you have to go there. Another option is that you don't get ranked and you just don't match and you don't have a place to go generally. There's some wiggle room around. So looking at all the applicants, MDs and DOs, in the era where both MDs and DOs are applying into the same types of residency, the paper categorized specialties into low competitive, middle competitive, and high competitive based on match quality score, based on available number of positions and the number of applicants that are applying into it. So, family medicine, internal medicine, low competitive, dermatology, plastic surgery, high competitive, it makes sense. Diagnostic radiology, where I'm at, middle competitive. So looking at the scores, this is whether they matched or not, period. So looking at the low competitive score, most people match, period. Medium competitive, more MDs match, but little difference. And in highly competitive specialties, still plenty of DO applicants match into these highly competitive specialties. This is not saying they're going where they want to go, like their top 3 choice. This is whether they matched or not, period. This is not a survey data. This is actual pure data that's being analyzed. So you can just see the difference here. If you watch my video, you'll find out that I did not match into my preferred specialty initially before going into radiology. Not matching is a big deal. It is the fear that all medical students have. So you want to avoid not matching as much as possible. But this is the best data where MDs are applying or matching into highly competitive specialties, and DOs are having a much tougher time. Just looking at their application, MDs have generally more research experience and research items, which makes sense. But DOs have plenty too. So there's opportunities if you look for them in both sides of the aisle. STEP score is higher for MDs. DOs have another big test to prepare for, but on average, MD applicants have higher STEP scores than DOs. Note that the step 1 score, the dreaded step 1, is going away. It already went away. It's already pass or fail. So you can suspect what that would affect. There's less numbers to judge applicants by. So other aspects of the application will be more important. This is looking at the number of programs that basically where they're interviewed at. So just looking at the highly competitive specialties, the MD applicants are, being interviewed at more places than the DO applicants. But for the low competitive specialties, the numbers are similar. Again, this is not speaking as to they're going to their top preferred program. It's whether they got in or not. All right, another Pear Deck question. I think more the better. That's the sense I got when I was helping pre-meds get into med schools. So enter a number. What percentage of DO doctors, what percentage of US physicians are DO doctors? lots of answers. The answer is 11% as of 2021. 25% of graduating medical students are DO, so that number will creep up over the years. Not 100%, or oh, these are skewed. All right. Second paper, a lot of you were interested in surgery. So this is basically looking at survey data of program directors. So these authors, DO school authors looked at, does the program have a single DO resident? Yes or no? And what's their geographic distribution throughout the US? That was basically the question. So 25% of people who were asked, residency program directors of 1,040 surgical specialties were, responded, and about 47% of respondents don't have a single DO resident, but plenty of them do. So this is the map where, if it's a light blue color, they don't have any DO residents. Gray means there's no respondents from that state. This basically tells me that Michigan has surgery programs with, DOs in them. That's basically what I'm getting out of it. Again, much harder to get in for DO school, DO applicants, but can be done, more MD represented. And, a lot of these residencies are, MD heavy. So, there might be biases that exist, but, I think that's wrong. But that's, it's hard to not be biased in things that you're already in. These are the feedback the program directors gave to osteopathic DO students. If you want to get into surgery programs, what can you do? And a lot of them said, research, doing a array rotation at that program, and then the step score, especially for general surgery. But again, step 1 score is going away, so we don't know how that's going to affect the application cycle. Not going away, it's pass or fail. So you should pass, but less numbers to gauge applicants. As Dr. Slade alluded, most DO doctors going to primary care. You can see the numbers, but still significant number of MDs going to primary care. And since there are about 10 times more doctors in MD than DO, they're still pretty well represented in primary care too. In Wisconsin, they love sending primary care doctors into rural Wisconsin, the Wisconsin idea. And I was almost convinced into going to primary care, but radiology won out in the end. All right, another difference in MD and DO is, who is doing the research. MD schools have been around longer, and they're more, I guess there's more physicians with an MD degree doing research. So it makes sense that, they would be more passionate and easier way to learn these research skills than DO doctors. So NIH R01 grants, call it like the holy grail of research grants. You need money to do research, and at a certain stage in your life, you'll need to get grants if you want to make research a part of your career to some degree. So this giant grant, multi-million dollars over several years for getting those. The past 10 years, basically, the MDs have dominated the field. And even in publications, there are DOs doing really good research for sure, but most are MD. And going to an MD school will introduce you to mentors and have the culture of getting grants even as medical students and publishing to get that skill set accumulated early. So in the end, I think MD versus DO matters more for undecided students. But I would argue that unless you know exactly what you want to do, it's hard to know what you will eventually be doing later down the road. For example, 75% of medical students changed their specialty choice, although this was surveying MDs only. And this is looking at students who stayed in the subspecialty that they thought they were going to go into. So 38% of people who went into pediatrics thought that they were going to do pediatrics, but the rest of them changed their mind. Neurosurgeons know what they want to do, and emergency medicine and family medicine following. Just as Dr. Slade's kind of survey showed, no one wants to go into urology initially, but a lot of people change into it. 71% thought they were going to do something else, but went into urology. Same with PM&R. So your specialty preference might change depending on what you're exposed to. So 56% of DO applicant or graduates go into family medicine. So that started at 30% when they started at the school, but it increased to 57%, which I think is excellent because we need primary care doctors in the US. But that's all I can say about that because I went into radiology, not primary care. And do you like research? Some of the research that you might be doing right now are bench related, working with mice or whatever. But there are many types of research that you might not have been introduced to. I think the correct way of thinking about this is you're going to run into problems in your career where you thought things were better. And if you want to be able to change that, then research is a way to, make those changes and invent things, make things better, program things, especially in the sides of, artificial intelligence and radiology. So MD school will give you more opportunity on average than a DO program. But still, majority of MDs do not do research. I'm just giving a plug for research because I'm passionate about it. All right, this is the last Pear Dot question. Here's a scenario. You or anyone applied to both MDs and DO schools, and you received a few interviews from both types of programs. In the end, you received offers from DO schools only, but no MD schools. And this is the typical scenario where I see when I was working for BMO Academics. I have yet to see a person who applied to both and only got into DO schools and only got into MD schools and no DO schools, and the applicant wanted to try more to go into a DO school. Not that there aren't people like that out there, but just from my experience. All right. So I think there is a correct answer here. Make a selection from the accepted DO schools is the right answer, because if you're not going to go to a school that's going to accept you, don't apply in the first place. Both ways. If you're not going to go to an MD school, don't apply to MD schools, and vice versa. And if you thought ahead of time, you would have been able to avoid this conundrum. Apply only to programs that you're happy to attend if they give you a acceptance. All right. So what kind of doctors you become? Mostly depends on you. Your degree does not define you. It's you who are going to be a good doctor, and you can make anything happen. Although one might provide a more path of least resistance, but if you wanted to make it happen, you can. Going to an MD program on average provides more opportunities in research, and going to a subspecialty of medicine. Decision to go to which medical school is very personal. Like Dr. Slade wanted to, it worked out for him because he stayed within the local area, close to family, which is probably more important than anything else really. And don't apply to programs that you won't go to anyway. All right, and I think we're now. And it's time for taking questions. So I think Avi is going to moderate that. Thank you very much for listening.
Thank you so much, both Dr. Jang and Dr. Slade. If we could see some applause from the audience, there we go, or applause from the audience. Thank you guys so much. Yes, we'll begin the Q&A section. Again, if you have any questions, please navigate to the Q&A tab on the bottom of your screen and just type your question in there. You can even type it anonymously if you would like. And also make sure to upvote the questions. I'm going to start reading the most upvoted questions and then go from there. So this first question with 6 upvotes comes from an anonymous attendee, and they ask, if DOs most frequently match into rural residencies, what are the pros and cons of this? What is rural medicine like? And I think this is mainly a question for Dr. Slade.
So you're not going to be at a university institution in a city where they have multiple specialties available to you. So in my experience in Kingman, Arizona, we're a rural area. So if we had something that needed neurosurgery, like a brain bleed out of the emergency department, then we had to get them in a helicopter and send them to Las Vegas or Phoenix. And you're also going to have a lot of people that don't have access to medical care. So we'd have people coming out of the desert with giant tumors or with their feet full of maggots. I mean, you'll get that in the city too, but you'll get some weird pathology. And then in Kingman, in rural residencies, you're the only resident. So we had some family medicine residents there as well, but we didn't have anybody competing for procedures or seeing patients. We had any patient we wanted to see was ours. Any procedure we wanted to do was ours. The downside, like I'm so glad I sent my slides to Dr. Jang because he added so much to what I didn't have. And that's true that in rural medicine, we had to travel a lot more. So I had to do my pediatric rotations, pediatric emergency medicine in Vegas. We had to do our trauma surgery rotations in Vegas. We had to do toxicology in Phoenix. Whereas if you went to emergency medicine program in a city or any residency program in a city, you'd probably have most of your residency in that area, which Dr. Zhang, which was awesome that he mentioned that.
Thank you so much, Dr. Slade. Another question from the audience is, it seems like there is not a lot of differences between MD and DO. To Dr. Slade, why should you choose DO over MD and vice versa for Dr. Jang?
I think you should choose DO if you've run out of time and resources and you were not accepted to an MD school, then you should go to a DO school if you've been accepted to one. Or if you're very passionate about OMT, then apply to only to DO schools and go to DO school if you're really passionate about osteopathic manipulative medicine.
Yeah, I agree with that. A lot of reasons to go to anywhere, proximity to home is very important. At some certain point, the difference in degree starts to not matter as much. Again, I think we went over those reasons quite well. For MD, the two, I guess, data-driven reason to go there is if you want to do a lot of research and if you want to go into like a super high competitive subspecialty, you can look up that paper. Is both MD and DO authors were on there, but it's just analyzing existing data. I don't really think that's research, but so if you want to do those, then try an MD. If not, you might still be able to get in. But in the end, again, whatever you're going to, you'll not regret it. Being a doctor is awesome.
Thank you both for the advice. Another question we have from the audience is, this one is directed to Dr. Slade. Dr. Slade, what was it like to start medical school not immediately after college? So not immediately after finishing the 4 years of college and then going straight into medical school.
I mean, there's, you don't regret your life. Like I think Dr. Zhang's point of no regrets is true. And I don't have, would I have liked to have gone back in time and knowing what I know now and go straight into medicine? Of course. What was it like? I had to go back and do prereqs, but it's easier going back to school I'm married and have kids. Like and I had, I figured college out by that time, and I got an MBA too. So it was easy for me to go back to school and do well. So I got 100, I was top my class in every class I was in. It was easier as an adult. But it was harder to do those things for medicine, like the volunteering and the research and for me to get a job in healthcare I was keeping my engineering job and getting paid very well and saving because I knew I was going to go to medical school. So it was harder for me to do those volunteering and that, having a job in healthcare aspect. So that was more difficult as an adult, not an adult, but as a older adult with family.
Dr. Slade started his medical school at my age right now, and I think that'll be very difficult. It's amazing how non-traditional applicants manage their time really well. It's good to not have any other responsibilities during medical school because it's so grueling. But obviously, Dr. Slade made it work and is doing excellent. If you love medicine, then you'll make it work.
Awesome. Thank you so much to hear. I know gap years are probably a big subject for a lot of students considering medicine and medical school. So it must be very, comforting to hear your perspective on that. Our next question is from Martina Georgis. I hope I pronounced that right. I'm sorry, Martina. But what happens if you don't get matched to a residency? And if you do match, but want to change paths later on, what can you do?
I'll speak towards that. So I do talk about that a little bit in my video. So if you don't match, there's a process called scrambling or soaping, where there's unmatched applicants and then unmatched programs. And you basically are struggling to make connections and try to go anywhere. It might not be in your desired specialty. There wasn't any in the specialty that I wanted to get into, radiation oncology, or in radiology. So, I was kind of on the fence. I still got into like an internship program. So I still had a place to go to the next year, but nothing was said after that. So for a week, you try, if you want, to try to go to a unmatched program, and your school gives you ample emotional support. There's a lot of love from family. I got so much free pizza during that week just to, eat my stress away. But let's say you still didn't match. It could be that you might have to apply again in the next cycle, which is what I did, into a different specialty or the same specialty after trying to improve your application in some way. I asked for feedback from the programs that did a match at, and some of them responded, like 20% responded. So I tried to make those changes. But I knew that going from a super hard specialty like radiation oncology to radiology, the match would be easier. Like my friend, he didn't match 3 times. That's thousands of dollars of application fees that just down the drain. But after he made the switch to psychiatry, no regrets. He's very happy. Which I thought he was gonna say, I still wish I would have gone to surgery, because he like breathed and bled surgery. So it's surprising for me to hear that he was happy in psychiatry. 2 very different fields. And in the middle, if you specialty, very possible to apply again to a different residency and match again. A lot of surgery residents come to radiology. We have some in my program because I don't know, they're burnt out in their surgery program, and radiology is happy to accept anyone as their second home.
Thank you very much, Dr. Zhang. One sec. Okay. Another attendee asked, does qualifying for loan forgiveness programs vary between MD and DO? Does DO get a better offer since they are more likely to do rural?
I guess in that aspect, maybe that's the case, but the degree is not the factor. It's the residency and the job.
There is a loan forgiveness talk coming up, so maybe that's a good question for the speaker then.
Perfect. Thank you, guys. Let's see. Another question from the chat is, does it look unfavorable to attend a DO school after being rejected from MD schools?
Nobody's ever going to see that you were rejected from MD schools. Nobody's going to know that.
Unless you tell them in the interview, I guess, but you wouldn't disclose that information. I don't know specific. I have met program directors, like I'm not going to say their institution, that have said they don't rank DO applicants, which I think is wrong. But their reason was because of optics, the bias, existing bias that is slowly going away. That is in looking at applicants. But very only maybe 3 total out of hundreds that I talked to. But that is changing.
It's frustrating for DOs to have that out there, but we're moving into every. Like I said, I think every residency is eventually going to have a DO or DO faculty at some point. Just it's a challenge.
I see. Thank you both. Another question, I think this one is specifically for Dr. Slade. Hi, Dr. Slade. I'm interested in emergency medicine. What is something I should know before pursuing emergency medicine, or something you wish you had known beforehand?
Emergency medicine is fantastic. It's great. No regrets, right? That's what I keep coming back to that. I love that you emphasize that so much. It's shift work. When I'm here, right? Well, now as a medical director, I do get emails and calls, when I'm not on shift, which is not great. But if you don't do a medical director, you can just go to your shift, and when you go home, you're done at the end of the day, and that's great. But what did I wish I knew? That I don't know. I think you do your research in whatever specialty it is, and you shadow, which I did, and you volunteer in emergency medicine, which I did, and whatever specialty you want to go into, emergency medicine or anything, and you see, is this really what I want to really? And in medical school, when you do in your clinical years, you get to do a little bit of that as well, and you get to see, I really wanted to do neurology, and then you go in and you do some neurology work, and you're like, maybe I really don't want to do this. What do I wish I had known? An emergency medicine has had a big shakeup in the last 2 years, where they came out with a report that we're going to be overstaffed emergency physicians, in the next few years. And you see that reflected in the match this year, where there was for lots of residencies didn't get their full match in emergency medicine, which was unheard of until this year for the last many, many years. And I think it's because of this report that there is some risk in going to emergency medicine. And so, but I get I get emails for emergency medicine all the time, but they're rural, emergency medicine jobs. If you're willing to go out and do rural emergency medicine, then there's plenty of opportunities. That didn't really answer your question, but I rambled for a moment.
Thank you, Dr. Slade. Let's see, any other? Another attendee asked, it seems like the DO education is disincentivized. Why is this? Do you think it should be that way? In my opinion, going through the extra training to touch and work with people in that way should be the more prestigious choice.
The prestige in medicine is, like Dr. Jang alluded to, in that is in research, and the highly prestigious research is, NIH grants, which you mentioned, but also randomized, placebo-controlled trials is the gold standard, just below, meta-analysis. And it's really hard to do randomized placebo-controlled studies with osteopathic medicine. So you're never going to have that prestige research with that. And also, going back to those YouTube videos, they do mention that some of these osteopathic treatment is not only not able to research well, but it seems very non-scientific, with cranial manipulation, where you're manipulating the head to affect the movement of the spinal fluid in the brain. And also, he didn't mention, but there's also Chapman's points, which are very good test questions for OMT, where you're finding spots on the body that reflect, the organs inside. And it seems it's not very scientific. And so the prestige in OMT, I see what you're trying to go for. And as far as patient satisfaction, as far as patients liking being touched, absolutely, you're right. They do like that. They do like the osteopathic manipulative treatment. But as far as prestige medicine, it's not there.
In terms of
Dr. Jang, what do you think about that?
In terms of performing OMT in your own practice, really depends on your job. If you're DO in radiology, you're not touching many patients. Or if you're, I don't know if Dr. Slade does OMT in his practice.
Very little.
There's very little. There is a recent, I think, publication 2020 or 2019. They surveyed DO doctors of how many actually do OMT. I think they should have surveyed OMTs in primary care who does OMT. I don't know how the methodology worked, but not every DO graduate will do OMT depending on your job. There's some jobs that literally OMT is not part of your practice, and you might actually be overstepping your boundary if you are, treating patients in that regard, like as a cardiothoracic surgeon, if you do OMTs on your patients. So I think it's really limited to a certain population. In the end, all that matters at a certain point is, do your patients appreciate and feel healed from it? That's my perspective. I thought some of the OMT stuff was grounded in, science. So, as long as, there is data supporting that it's helpful, then I'm all for anything.
There is some, but they're not the prestige, randomized controlled trials.
Prestige is, as he said, academic based in, Ivy League, research grants. US News Ranking uses that a lot. So, the public's perception is going to be swayed.
Thank you both so much for your answers. I think we only have time for one more question. So I wanted to do this one from the chat that had a lot of likes, but Jamie asked, what subjects or courses in your undergrad helped you the most in the DO program?
Nothing specifically as far as OMT helped me in undergrad. what could you take that would help you with OMT?
Anatomy.
I don't know. Maybe what would you say?
Anatomy, maybe.
Anatomy. I didn't take anatomy. I would have. I would love. I say this in my mind all the time, and I'd love to take medical school before medical school, which is, not only the prereqs but also anatomy, physiology, pathophysiology, pharmacology, anatomy, immunology, microbiology, all those things because then when you go to medical school, it can be more of a review and not you're learning it for the first time. Some of it, even if you take the prereqs, it is, review, but there's so much more new stuff. There's also some programs, including Toro, Nevada, which offers a master's program, Master's of Science, where they actually take the classes along with the DO students and anatomy as well. And when those students get accepted to the DO program, they were the top of the class because they'd already had medical school before they went to medical school. And I think that's genius. If your program you want to go to has that, I would say do it, especially if you want to go into a highly competitive specialty.
Well, I think that's all the time we have for our questions. I will send most of the questions that I see here in the chat and the Q&A, I will send to Dr. Slade and Dr. Jang. If either of you guys have any, social media or emails that you would like to share as well, so that attendees could answer questions, you can go ahead and add that in the chat. If you don't want to or don't feel like it, no worries. But thank you all so much for coming to this session, for attending this session. I hope you took away a lot. I know I took away a lot because I feel like this is a good informational session just to learn, like, first of all, what the difference is, and then, making the actual decision when the time comes. But again, thank you all so much for coming out to this session. And please check out our next session, which is on loan repayment, which kind of goes hand in hand with one of the questions that was asked during the Q&A session. So in order to attend that next session, you'll leave this webinar, go back to the lobby, and then you'll click join once that join button shows up on the loan repayment seminar, just to make sure it's all clear and such. But again, thank you both, Dr. Jang and Dr. Slade, so much for coming out to speak. And thank you to the attendees for listening. Yeah, that's all that we have to say. We'll see you in the next session. Thank you all so much. Goodbye.
All right. Thank you, Avinash. Nice meeting you, Dr. Slade.
Hey, thank you. And I put my email in the chat if anybody has any questions for me. Thank you, Dr. Jang. Thank you.